So, we're going to now talk about the basic pharmacology of both thyroid and anti-thyroid drugs, and we're going to start with the anti-thyroid drugs. The purpose of these drugs is to reduce thyroid activity and to reduce the hormonal effects of T4 and T3. The approach will be to use drugs that change tissue responses to thyroid hormones, or to literally destroy the thyroid with surgery or with radiation. So, by definition, these compounds are referred to as goitrogens. And the name goitrogen, or the word goitrogen, would suggest something that generates a goiter. And so these compounds, are going to suppress thyroid hormone secretion, and TSH levels are going to therefore go up because of the negative feedback loop being disrupted, right, between the thyroid hormone release and the pituitary gland. And so this increased TSH can trigger the thyroid gland to get bigger, and in some patients actually develop a goiter, an enlarged thyroid. The drugs we'll discuss in antithyroid category will include the thioamides, the iodides, and the radioactive iodine. The major drugs for thyrotoxicosis are the thioamides, and there's three that we'll discuss. The first of them is propylthiouracil. Now, this drug is absorbed rapidly. Its bioavailability is between 50 and 80%. There's incomplete absorption of this drug. There's the potential for a large first-pass effect, so there's a wide variation in bioavailability. The drug is metabolized through glucuronidation by the liver and excreted through the kidney. And it possesses a short half-life, about 1.5 hours. However, the drug is accumulated by the thyroid. Okay, so you might not see it in the blood after several half-lives, but the drug will be in the thyroid. And so it crosses the placental barrier, and it exhibits increased protein binding compared to another drug we'll discuss soon called methimazole. And because of that, propylthiouracil is preferable for use in pregnancy, since less free drug is available to cross into the fetus. Methimazole is about 10 times more pharmacologically active than propylthiouracil. It's well absorbed, it's accumulated by the thyroid, and it also... So the major mechanism of action of the thioamides, the predominant action, is to inhibit thyroidal peroxidase catalyzed reactions, which block iodine organification and prevent coupling. So T4 and T3 can't be formed because the tyrosines on thyroglobulin won't get organified by iodine, and there won't be a subsequent coupling of MIT and DIT and so on and so forth. So propylthiouracil and methimazole, although to a much reduced degree, inhibit peripheral deiodination of T4 as well. So these drugs are both also capable of blocking peripheral 5' deiodinase. These drugs have a slow onset of pharmacological effect. They often require 3 to 4 weeks before the T4 levels will drop to normal, to what they should be. Remember, these are drugs you'll give in a hyperthyroid instance. Now, in terms of adverse effects, the most frequent adverse effect observed is maculopapular pruritic rash. Potential for granulocytosis is seen in people with who are taking thioamides, which is reversible upon discontinuation. And although there was some speculation that there may be cross-sensitivity between propylthiouracil and methimazole, recent studies have ruled that out. People who are possibly at increased risk of the toxicity of thioamides are the elderly or those receiving high-dose methimazole. Carbimazole is a prodrug It's not widely used in North America, but it is used in Europe, and particularly Great Britain and continental Europe. And I'm only going to briefly talk about it here, but it's an interesting compound because it's a prodrug. It will be rapidly and completely converted to methimazole after oral administration. In fact, only methimazole has been detected in the plasma or other body fluids or in the thyroid in patients who have taken carbimazole, so it's believed to be completely converted to the drug we call methimazole. And realize that methimazole, when it's being metabolized, is metabolized in part to an active metabolite. It's known as 3-methyl-2-thiohydantoin, and this methimazole metabolite has some activity, not as much as methimazole, but nevertheless would be considered an active metabolite. So the majority of the carbimazole dose, or the methimazole that is formed, will be excreted in the urine, primarily as metabolites. A small fraction, about 7 to 12%, has been recovered as unchanged methimazole. And the elimination half-life of methimazole following that oral administration of carbimazole has ranged anywhere from 3 to 13 hours. So there's some variability there in terms of half-life. Now, clinically, carbimazole has been effective in the treatment of Graves' disease or thyrotoxicosis from other causes. But since the drug is completely converted to methimazole and does not appear to have an advantage over methimazole in treating hyperthyroidism, it's not commonly used in the U.S. Rather, other thioamides such as propylthiouracil or methimazole, they are used in the treatment of thyrotoxicosis. Now, these thioamides have some primary adverse reactions, particularly skin rashes, pruritus, arthralgias, or joint swelling have been observed in some patients. Granulocytopenias, agranulocytosis is something to worry about in patients who take thioamides, and in fact they will be monitored. Their blood counts will be taken regularly just to keep an eye on granulocytes. In addition, cholestatic hepatitis has been reported in some patients, and in fact propylthiouracil has been known to cause hepatic failure in some patients. In fact, that's even been recently put onto the label, or the package I should say, a warning label for the risk of liver failure in patients taking propylthiouracil. It's still relatively uncommon, but has been observed. And there are other less common adverse effects observed with the thioamides, such as nausea, alopecia, and some others. But I think the big concerns here are the risk of agranulocytosis with all the thioamides, and the recent warning concerning propylthiouracil and liver failure. So in terms of hyperthyroidism, hopefully this is a review, but really the cause of the disease can be one of several, but in general the bottom line is too much free thyroid hormone, excess free thyroid hormone being produced. And that thyroid hormone is going to have effects throughout the body. Remember, thyroid hormone is able to penetrate many different tissues. There are receptors for it all throughout the body. And its effects will cause things like increased metabolic rate, increased oxygen consumption. The thyroid gland may become enlarged or nodular, or in some cases it might appear normal. Symptoms and signs may range. They might be mild, they might be severe. But lab tests almost always will point to a low TSH and a high T3 in the hyperthyroid patient. In addition, total and free T4 are usually increased. Now, the most common cause of hyperthyroidism is Graves' disease. That's the autoimmune disease in which the immune system produces antibodies against the TSH receptor. This will result in a non-suppressible overproduction of thyroid hormone. Because remember, normally there's a feedback inhibition. As the levels of T4 and T3 increase, they will feed back onto the pituitary. The pituitary will stop releasing TSH, and thyroid hormone levels will go down. Here we have a non-suppressible overproduction of thyroid hormone. In addition, Graves' disease will be frequently associated with exophthalmos and swelling of the periorbital tissues, and usually there will be family history of Graves' disease and autoimmune thyroiditis in patients who develop hyperthyroidism. And so all kinds of physiological effects to be concerned about in the hyperthyroid patient: increased basal metabolic rate, the negative nitrogen balance, the hyperglycemia that can occur, the effects on free fatty acids, decreased cholesterol and triglycerides. The patient will become heat intolerant. They will start to sweat. Their skin might be moist. They're going to increase their CO2 production. They may become restless. The eyes, periorbital edema, and exophthalmos are of concern. Polyuria may be observed, and definitely effects on fertility, decreased fertility in the hyperthyroid patient. Menstrual irregularities in females with Graves' disease have been observed. Increased steroid metabolism, and lest we not forget the effects on the heart. Remember, thyroid hormone helps catecholamines do their job better. So the heart rate goes up, the cardiac output can go up, the blood pressure can go up. In fact, one thing you worry about in hyperthyroid patients is, arrhythmia, because the heart's beating harder and faster than it should because of the excess levels of thyroid hormone. So a few other treatments are available, a few other drugs are available to treat hyperthyroidism other than the thioamides we've mentioned. These include a drug like Ipodate. Ipodate works to reduce T3 and T4 levels in the blood. It's noted that the effects may be transient and that long-term use may actually cause or aggravate thyrotoxicosis. Okay, but in the short term, Ipodate inhibits T4 to T3 conversion. It's used successfully as an adjunct treatment in preparing patients with Graves' disease for surgery to remove their thyroids or to have their thyroids partially removed. The adverse reactions primarily associated with Ipodate that are serious and worth knowing, worth being aware of, are things such as thrombocytopenia, hypersensitivity reactions, nausea and vomiting, headaches, cardiac arrest, dysuria. And of course, we're seriously concerned about risk of thrombocytopenia and disseminated intravascular coagulation that can occur. Iodine 131, radioactive iodine, has a half-life of about 8 days. This drug works by entering the thyroid tissue and emitting radiation, which will become toxic to the tissue. The tissue can begin to die, and therefore will not release as much thyroid hormone as if the radioactive iodine were absent. And this is a way of controlling the release of thyroid hormone. And propranolol, beta blocker, can be used to attenuate signs of adrenergic excess in hyperthyroidism. So the major cause of thyrotoxicosis will be Graves' disease. And generally, people with Graves' disease will exhibit either a hyperthyroidism with a diffuse goiter, or they might have a dermopathy or an ophthalmopathy. The thyroid itself will generally be soft or enlarged, might be highly vascularized. The thyroid parenchyma might be exhibiting hypertrophy or hyperplasia. There may be lymphocytic infiltration that would suggest an immunologic response or an immunological nature of the disease. And the autoimmune component, of course, will be producing this antibody that, rather than just binding and neutralizing something, is binding and activating its target, which is the TSH receptor. The management of this disease is therefore achieved through drugs such as antithyroid thioamides, such as the propylthiouracil or methimazole, thyroidectomies, radioactive iodine, or propranolol to control tachycardia, hypertension, and atrial fibrillation. Now, among the antithyroid agents which we haven't yet discussed are the anion inhibitors, and these work by competitively inhibiting the sodium iodide symporter. These are going to include drugs such as perchlorate, pertechnetate, and thiocyanate. The major one used clinically is potassium perchlorate, but even that is not often used because of the possibility of aplastic anemia forming in the patient. Blockade of thyroid gland reuptake of iodide in patients with iodide-induced hyperthyroidism is another use for these drugs. Now, the iodides work by inhibiting thyroidal peroxidase. These are rarely used now as monotherapy, and their actions on the thyroid include, because of TPO inhibition, include the inhibition of organification, the inhibition of hormone release as major actions, of organification, of coupling, of the TPO-mediated effects. And, of course, the effects on hormone release have been observed with the iodides. The mechanism involves inhibiting thyroglobulin proteolysis, and decreased thyroidal size and vascularity, which can occur because of the iodides, may actually induce a hyperthyroidism called Jod-Basedow. It's like a paradoxical hyperthyroidism that can occur, or may precipitate hypothyroidism, as a consequence of treatment. So, these drugs are rarely used now, again, in monotherapy, but have been used in the past and work in this way. In terms of clinical considerations with the iodides, the drugs may be useful in short-term management of thyroid storm, and they may be helpful in preoperative preparation for surgery because they reduce the gland's vascularity, size, and fragility. But major disadvantages of the iodides is that therapy with them increases intraglandular iodine concentration. It can affect the initiation of thioamide treatment, or may delay the use of radioactive iodine because of accumulating in the thyroid gland. Chronic iodide use in pregnancy, better to avoid this because iodide crosses the placenta and may cause fetal goiter. So we don't want to inhibit formation of thyroid hormone in the growing baby. Now again, this is not the regular supplementation of iodide that all pregnant women should have, or people need to obtain from their diet. And we're talking about now the drug iodide being given, which can induce hypothyroidism. So note that the block only lasts about 2 to 8 weeks, and withdrawal can exacerbate thyrotoxicosis. So if it's going to be used, the iodides should be initiated only after thioamide treatment and not used if radioactive iodine therapy is planned. Now, radioactive iodine, I-131, is the radioactive isotope that's used to treat thyrotoxicosis. In terms of mechanism, it's rapidly absorbed and concentrated in the thyroid. It's incorporated into thyroid follicles. It emits beta rays into surrounding tissue, causing that tissue to eventually die. The thyroid parenchymal destruction usually starts to occur within a few weeks. What's good about this drug? It's very efficacious. It's easy to administer. It's pain-free in terms of how it's treated, and it's not very expensive. However, the drug is contraindicated in pregnant women or in nursing mothers because it can cross the placental barrier and it is excreted into breast milk. Now, the adrenergic receptor blocking drugs can be used as antithyroid agents with the rationale that they will reduce the sympathetic manifestations of thyrotoxicosis. Usually we're going to be talking about the beta blockers, and the agent of choice is propranolol. This is a non-selective beta blocker, although there are others. Guanethidine can be used, which competes for uptake into norepinephrine vesicles and depletes vesicular stores of norepinephrine. The idea here is to block sympathetic stimulation or reduce it because thyroid hormone makes it work even better. So here, if you can get to the sympathetic side of the equation, you can perhaps reduce some of the toxicities. Now, in hypothyroidism, this is going to occur when the thyroid gland is not producing enough thyroid hormone. Symptoms may vary from mild to severe, from non-specific to very specific, but in general, all metabolic processes slow down. There might be high cholesterol, there might be mild anemia, there might be high serum enzymes, including CPK. The T4 and free T4 is low, and the TSH is always high. T3 may be normal. Secondary hypothyroidism is defined as the failure of the thyroid gland due to the inadequate production of TSH. So failure of the pituitary or as the result of hypothalamic dysfunction is another cause. And lastly, pituitary failure can result from destruction by pituitary and non-pituitary tumors, by head trauma, by radiation, by postpartum infarction, or through idiopathic causes. Now, I think Dr. Hughes will talk a lot more about the clinical side of hypothyroidism. Okay, but this is just a broad overview of general concepts in this area that I gleaned from our textbook. Now, in hypothyroidism, decreased basal metabolic rate, there might be a slightly positive nitrogen balance. We might get effects on the kidney that lead to water intoxication. The patient becomes intolerant to cold. They always feel cold. They might be lethargic or confused. Their skin is pale. There might be effects on their lipids, such as cholesterol going up and triglycerides. Cardiovascular effects, the heart rate might be slower than it should be, as the cardiac output as well. Decreased appetite, decreased bowel sounds, decreased water loss, decreased fertility and libido. All of these things can be the result of not having enough thyroid hormone, hypothyroidism. Now, hypothyroidism in development is very dangerous. It can lead to something called cretinism. This is when hypothyroidism is present from birth, and it will be accompanied by developmental abnormalities. Myxedema is another event associated with hypothyroidism, particularly severe hypothyroidism, when there starts to deposit crystals, deposition of hydrophilic mucopolysaccharides in the dermis and other tissues, which can cause the appearance of a facial thickening or a doughy skin. Particularly, we worry about myxedema as a sign of hypothyroidism and the need to now go for treatment. There can be swelling of the skin and other tissues, usually shown off as puffiness around the eyes and cheeks. Sometimes this is called hypothyroid-related swelling. So these are some of the things that can be observed in the patient. Now, in hypothyroidism, we have inadequate thyroid hormone synthesis, causing TSH levels to go up, which can cause a goiter to form. In North America, the most common cause of goitrous hypothyroidism is an autoimmune disease called Hashimoto's disease. Thyroid hormone replacement therapy. Thyroid preparations which are available for dispensing include synthetic or animal-derived. The synthetic forms are levothyroxine, liothyronine, or Liotrix. The animal-derived is referred to as desiccated thyroid. Synthetic levothyroxine is currently the preparation of choice for thyroid hormone replacement therapy due to its stability, its uniformity, its low cost, its lack of an allergenic foreign protein, easy lab measurement of serum levels, and its long half-life of about a week. Liothyronine is 3 to 4 times more active than levothyroxine, and it's not generally recommended because of its shorter half-life, because of its greater activity, and due to that enhanced pharmacologic activity, is greater risk of cardiotoxicity. Recall that thyroid hormone upregulates beta receptors in the heart, and in hyperthyroidism, the heart's beating harder and faster than otherwise would. And in fact, in the elderly, one concern of thyroid hormone excess is increased risk of AFib, atrial fibrillation. So cardiotoxicity goes together with high activity of thyroid hormone, higher than normal. And so generally the liothyronine is avoided and the levothyroxine is used. This slide summarizes the types of products available to treat hypothyroidism. I've put a box around levothyroxine, which is the most common form, but there are still other products available as mentioned, like liothyronine, which is the T3 hormone, or Liotrix, which is a mixture of T4 and T3, 4-to-1 mixture. And the animal-derived product is desiccated thyroid. But again, I put a box around that one, which is predominantly dispensed at the present time to treat hypothyroidism. So, patients got hypothyroidism. They're being treated with levothyroxine, T4. We should pay attention to some drug and food interactions that can impact T4. So there are some drugs and some foods that can interfere with the absorption of T4. Again, this drug is given orally. And drugs that can interfere with T4 absorption include cholestyramine, a cholesterol-lowering drug, cholestyramine, another cholesterol-lowering drug, ciprofloxacin, proton pump inhibitors. These are several types of drugs that are known to interfere with the absorption of T4. In addition, there are certain foods that can interrupt or disrupt the T4 absorption, including bran, soy, and coffee. There are certain drugs that are known to have a small but significant chance of inducing autoimmune thyroid disease. And these include lithium, which is a drug used in the treatment of certain neurological conditions such as bipolar disorder, and amiodarone, which is a drug you've learned about in cardiorenal as a treatment for arrhythmia. And it's interesting, lithium is able to enter the thyroid gland through the sodium iodine symporter. It's small enough to get through that and enter, and seems to disrupt the activity of the thyroid gland in that regard, predisposing it to this disease state. On the other hand, amiodarone is interesting because why? What kind of substitutions are on the structure of amiodarone? Oh, well, if you're not recalling right now, you'll probably discuss that in the medicinal chemistry portion, that the iodides amiodarone has iodide in its structure, and so that iodide can target the thyroid gland. And lots of things have been documented depending on the state of the patient's thyroid gland. But definitely a small but significant increased risk of autoimmune thyroid disease. Then there is inhibition of 5' deiodinase, which leads to decreased T3 and increased reverse T3. And so by inhibiting 5' deiodinase, you're reducing the pharmacologic effects of thyroid hormone in the periphery. And drugs capable of serving as 5' deiodinase blockers include drugs like ipodate, amiodarone, non-selective beta blockers such as propranolol, certain corticosteroids. Propylthiouracil has an ability to block 5' deiodinase, as well as certain flavonoids. Okay, so several types of drugs can block 5' deiodinase and precipitate hypothyroidism. That may be undesirable, that may disrupt your therapy, or, and if we're in the case of thyrotoxicosis due to, severe hyperthyroidism, this is one way of dealing with that, because you're taking all that T4 that's been produced and not letting it get turned into the more active T3. Again, thyroid function, proper thyroid function is critical because in conditions of altered thyroid function, there can be altered drug effects. This is a selected list from our textbook. And for example, in the area of anticoagulation, lower doses of warfarin will be required in patients with hyperthyroidism, while higher doses of warfarin are needed in hypothyroidism. And so that's important. You want the patient to have normal thyroid hormone levels and have received treatment for that, so that the dosing of a drug like warfarin is correct and that the patient's got normal thyroid hormone function. So again, altered thyroid status can impact the efficacy of certain drugs. So in terms of glucose control, just in general, we have increased hepatic glucose production and glucose intolerance in hyperthyroidism, but impaired insulin action and glucose disposal in hypothyroidism. In terms of certain cardiac drugs, higher doses of digoxin are needed in hyperthyroidism, while lower doses of digoxin are needed in hypothyroidism. In terms of sedatives and certain analgesics, increased sedative and respiratory depressant effects from sedatives and opioids in hypothyroidism, and the converse in hyperthyroidism. So hopefully patients who you're taking care of are going to have normal thyroid function, because altered thyroid function can affect the activity of drugs for other things that they may be suffering. And so we don't want to see any unwanted toxicities due to that. A very severe type of hyperthyroidism, a very severe form of thyrotoxicosis, is referred to as thyroid storm. This is a fulminating increase in the symptoms of thyrotoxicosis, like thyrotoxicosis, which is happening in a big way. Sometimes it's precipitated by surgery or a complicating illness, often sepsis. So, a patient that's got hyperthyroidism, very ill, may develop sepsis. All of a sudden, their thyroid gland goes nuts and starts to produce tons of thyroid hormone. And you see an acute exacerbation of all the symptoms of thyrotoxicosis. So presenting syndrome. Patients extremely irritable. They might be delirious. They might have already entered into a coma. So very high fever, because remember, thyroid hormone causes cells to be metabolically active, and metabolism generates heat. Tachycardia because of effects on the heart. Hypotension has been observed in some patients because, well, let's see why. So you have tachycardia, you have thyroid hormone levels being sky high. Thyroid hormone levels are going to increase the sensitivity of the myocardium to stimulation by catecholamines. So the heart is going to start to race and beat faster. It may be that a reflex is kicked in, where you get a reflex bradycardia. But why the hypotension? I'm gonna look into that in a moment. Patient may be vomiting. Patient may have diarrhea. So thyroid storm, big problem, urgent need to fix. Cannot let just kind of resolve on its own, because the patient may die. So because the heart is beating harder and faster, thyroid storm actually is going to first induce a hypertension response, or may induce a hypertension response, that may eventually be followed by a congestive heart failure symptomology that is also associated with hypotension and shock. Okay, so the hypotension is going to be further on in the course of thyroid storm, and at a more dangerous phase during thyroid storm. So in fact, in the early stages, the kinds of symptoms you see will be the ones I listed on the previous page. Irritability, the patient's agitated, their heart's racing, their blood pressure may actually be up. But at some point, if it's not controlled, if it's not treated correctly, the heart can start to fail, followed by hypertension, followed by hypotension, followed by shock. Okay, so that is why hypotension is listed in the whole list on the previous page. And I don't want to spend too much time on this per se, because this is going to be a hospital setting treatment approach. So how will it be treated in the hospital? Well, propranolol is a helpful drug here to help control the cardiovascular complications, right? So the heart's racing, the beta receptors are active, and so propranolol is going to slow down the heart. And it also has a secondary pharmacologic action by acting and inhibiting 5' deiodinates. And that's going to reduce T3 levels in the periphery. Now, if propranolol is contraindicated, diltiazem may be used. Potassium iodide is used to inhibit release of thyroid hormones from the gland. Propylthiouracil may be used to block thyroid hormone synthesis. Glucocorticoids will protect the patient from shock and block the conversion of T4 to T3 by inhibiting 5' deiodinates. This is a schematic of the thyroid hormone receptor. It points to certain regions in the receptor which are important for the transcriptional regulation of genes by thyroid hormone. So thyroid hormone is a agent that's going to enter cells through simple diffusion, and it's going to go into the nucleus where it's going to bind to these receptors and activate these receptors. So there's a binding site for T3 that the receptor is going to code for. There's a binding site for the DNA, the promoter region, on which the drug-bound receptor can bind and begin the process of gene transcription of proximally located genes. And so you see we have a T3 binding region, a dimerization domain. We see that this is receptors in the nucleus, has a nuclear localization domain, a DNA binding domain, a transactivation domain that allows for the transcription machinery to come and transcribe the proximal gene to which the promoter is being stimulated by thyroid hormone-bound receptors. And so these receptors look something like this. We have several types of thyroid hormone receptors. We have alpha and beta receptors. They generally bind to T3 quite well, with one exception, but we won't focus on that one exception in the moment. Generally speaking, these will be receptors which are strongly bound by T3. And so if you look at T3, it's coming in. How is it getting there? The T4 is being converted to T3 in the periphery by 5' deiodinase. It's coming into the nucleus. It's binding the thyroid hormone receptor. It's forming a complex with another receptor. Here, that other receptor is called a rexinoid receptor. And that TRE stands for thyroid hormone response element. So the drug-bound receptor sits down on the promoter and transcribes, begins the process of gene transcription of those genes. So the mechanism of thyroid hormone action is via its nuclear receptor. Thyroid hormone diffuses across the plasma and nuclear membranes to bind its receptor. The thyroid hormone receptor is localized almost exclusively in the nucleus, where it is associated with DNA as a homodimer. That means two thyroid hormones associated together through two adjacent thyroid hormone receptors, or as a heterodimer with one thyroid hormone bound receptor and a second receptor being the rexinoid receptor. And that hormone activated receptor binds to thyroid hormone response elements called TREs, and that results in altered rates of gene transcription and consequently increases in levels of messenger RNA. Now you see at the bottom, this says increase or decrease in gene expression, and the reason for that is that thyroid hormone can actually, in some instances, increase transcription of certain genes, in other instances, decrease transcription of certain genes. Many of the genes involved with cellular energy turnover. And so when we look at the next slide, we're going to see genes that are turned on, genes that are turned off by thyroid hormone binding to its receptor, traveling to the nucleus, and sitting proximal to genes, either activating their expression into message or inhibiting their expression into message. So this is just an example of a thyroid hormone response element. You see here you have GGTCA followed by 4 nucleotides of any variety, followed by AGGTCA. Right? AGGTCA followed by 4 nucleotides of any orientation, followed by another AGGTCA. This response element binds to the thyroid hormone receptor, but the thyroid hormone receptor only binds there if it's bound by thyroid hormone. And so this is a microarray experiment, and I'm not here to have you remember all the details of the experiment, but this is showing the results of a study following exposure of animal to thyroid hormone. And as you can see, various tissues are collected and represented on this microscope slide, or this gene chip, if you will. So you see the heart, the liver, the kidney, the pancreas, and all the major organs are represented here. As you go down from top to bottom, you see a lot of synthases, dehydrogenases, members of the electron transport chain, and so on. So most of these enzymes that are being expressed are going to be part of energy consumption, so part of glycolysis, part of citric acid cycle, part of electron transport chain, and beyond. And so why I like this figure, which is pretty old at this point, but why I like this figure is that green means that gene is activated by thyroid hormone, red means that gene is suppressed by thyroid hormone, and black means there's no effect of thyroid hormone on the gene. And so thyroid hormone is a very interesting drug because it literally affects the transcription of hundreds of genes. Most of them have to do with cellular energy turnover, generation of body heat, and so on. But if you look at the chip, you can see lots of greens, you can see lots of reds. And so in a way, it simplifies all of the hundreds of different genes that are on this chip in one regard. And that one regard is, yeah, thyroid hormone is doing a lot in this particular tissue. Some of what it's doing is stimulating gene expression, some of what it's doing is inhibiting gene expression. But nonetheless, there's a lot of effects of thyroid hormone being revealed by this study, right? So it's not just that thyroid hormone does, activates one single enzyme and we're all done here. It actually activates the expression of many, many, many genes. And those many, many, many genes come together for metabolic purposes and to keep the cell supplied with energy. This slide is just meant to show you the different types of tablet colors for levothyroxine and the different types of doses that are available, all the way from 25 micrograms up to 300 micrograms in a particular tablet. And so we have various colors, orange being the lowest, the 25 microgram. We have violet, which would be the 75 microgram. We kind of have some intermediate doses between 75 and 100, the 88 microgram dose, and olive green. And so you'll learn about the dosing from Dr. Mazzola. I'm just mentioning this here so you have like a point of reference to link up the chemical structure of T4 that we've been talking about here with what actually the pills look like. Now again, in terms of drug interactions, may increase the effects of oral anticoagulants. Cholestyramine may decrease the absorption of levothyroxine. It may decrease the effectiveness of digitalis glycosides. Adverse effects other than those which would indicate overdose are rare, but overdose can result in hypermetabolic states resembling those of the body and can include things like fever, hypoglycemia, heart failure, fluid loss, tachycardia, anxiety, and insomnia. Basically symptoms similar to that of thyroid storm and in line with thyrotoxicosis. Now, the effect of thyroid hormone in correcting thyroid hormone deficiency is one which is not an immediate effect. I'm not sure if that's on this slide, but I should tell you that. Usually, a patient's going to need to be taking their thyroid hormone replacement for several weeks to a month or two before they actually feel better. Okay, so there's a lag time. Why do you think there's a lag time in response? Because this is a gene modifier, right? And the genes have to be transcribed and they have to be translated and they have to get to a certain place so that these certain assays can be done. Now, if I'm mumbling a little bit, it's really late, and I've been up a long time. But basically, what I'm just trying to stress from this slide is, some of the pharmacology in terms of pharmacokinetics, drug interactions, and adverse effects. The information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation.
Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete the course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration.